I want to talk to you tonight about something a little bit more general than what our other speakers have talked to you about. I want to talk about our responsibility as people designing services to make sure that we're pushing for more inclusive services, so services that are designed right from the heart to include their users. So making sure not only that we're designing with and for people and including them in the process, but we're properly rethinking what those services need to look like in the future so that people are really in the middle of it all. And I'm going to do that through chatting through an example of a project that we're working on in FutureGov at the moment, which is in a hospital environment in Essex, where we're looking at how to help with the experience of getting older people out of hospital and to home, wherever that home may be. So, quick hello from me. So my name's Kirsty. If you want to say nice things about this talk, you can use Kirsty_Joan. So I am a service designer. I work for FutureGov. I've been there for a couple of years, and we're really proud to be 10 years old this year, which is quite cool. It's really lovely to have been working in this space, making good services and building a sort of a collective knowledge within this area for 10 years, which means that when projects like this pop up, we're able to bring all that knowledge together. We work on a range of issues. A lot of our work takes us into children's and adult social care, especially within local government. But we also touch into housing, sort of work with employment, environmental aspects, and do a little bit of work with some charities and some sort of international development work as well, which keeps things fresh and interesting. So, but the project I want to talk to you today is sort of the first project that we as a company have worked on, and I've personally worked on, which sort of bridges that, not bridges that gap, but sort of looks at that space in between where social care, adult social care in particular, provided by councils up and down the country, and the NHS sort of overlap. So when you're in that process, you've been in hospital for a little bit of time, and you've been declared medically fit, which is something which everybody relates to. What is then the process where you're kind of handed between NHS and social care teams, and all of the people involved in that process, all of the sort of uncertain language, acronyms that you're introduced to, and actually what that process looks like, and ideas as to what it could look like in the future. So this is the space that we're working in. It's messy, it's non-understandable, it's difficult to navigate, and it's really confusing for people. So we were given the brief to look at redesigning the experience for older people leaving hospital. And right from the word go, we wanted to make sure that this was something which included a whole range of people who sort of go through that process, are next to people going through that process, are worried about people going through that process. We knew that was going to need to include a lot of time with a lot of people. But we also wanted from the get-go to make sure it was a project where we sort of tested ourselves to reconsider what that service should look like in the future, that we were really wanting to sort of challenge our stakeholders and sort of shift their thinking in terms of the service that they were provided. It wasn't just doing the same thing but with the internet, it was probably wanting to change it to make people's lives better. And that's what we wanted to get out of it. And just as a little reminder as to why projects like these need to go ahead, facts like these we sort of see and hear every day in our work, in our projects, on our headlines, and we kind of get a little bit forgetful of them. But I think the fact that we've got an ageing population who are finding it difficult to do a large and growing number of care needs, the money going towards that is getting smaller by the day. Those cuts are happening every single year. We see it in budget reports, we see it in newspaper articles and everything. And also the sort of the market that's put together in order to provide the care for those individuals is shrinking. It's not fit for purpose. It's really difficult to access. And I think seeing stuff like this, we get a little bit forgetful because we see this so often, but really we're running out of time with this. We don't have many options to keep playing and inventing and trying different things. We really need to start addressing this. So as an individual who's going through that process, or helping a family member who's recently been in hospital to leave and think about what the next part of their life is going to look like, how to adjust for that, you might turn to a sort of notable authority such as Age UK to get some advice and some guidance on that. And it's not great when the thing that they tell you on their website is that this is going to be really complex. You're probably going to need someone to guide you through it. You're going to get some assessments. It's going to be difficult. Doesn't start off on a good foot, does it? So with that in mind, looking at our brief in terms of helping people, redesigning that experience of leaving care, We wanted to spend time with people who'd recently gone through it, people who are going through it at the moment. So we spent an awful lot of time in hospital, hanging out with people who do the job of sort of passing people between NHS and social care. Those people are called patient flow. That is a job title. And they are people who essentially are like human email chains. They do the job of walking around hospital wards, passing faxes and printed emails between different departments because the IT system cannot do that. So we spent a lot of time shadowing people, understanding their working methods, understanding sort of the needs and interests of social workers working within hospitals and helping families to sort of prepare for those difficult moments of actually what is it that we're going to need help with. Spending time with patients themselves, with the families that are supporting them, the people that are worrying about that, the people that don't quite know what's going to happen next, and just making sure we had a sort of a rounded view around that experience of leaving care. Leaving care? That's another project I'm working on. So I'm going to quickly talk you through 3 slides which sort of pull together some of the main insights from that piece of work in terms of spending time with people in hospital and in their living rooms if they've recently left hospital care. So the first thing that really hit us is that people aren't really certain what it is that they're going to need. If you've been rushed into hospital because you've had a fall, you've had a stroke, you've had a recent diagnosis, things in your life are changing, you're adjusting to that. You've probably not adjusted to that quite yet because you're in an unfamiliar environment, you're surrounded by care, you've got people feeding you and making sure that you've got all the care that you need right there and then. So your mind isn't really at what's going to happen next. So when you do have conversations with healthcare professionals, and you will have a lot of those conversations that last probably 10 to 20 minutes, it's really difficult to get the best out of those conversations because you're not quite sure what it is that you should be saying. You don't know how to answer the questions properly. You don't know what your life is going to look like from this point forward. So the questions that are being asked aren't really fitting. And it's also really difficult to ask people to make all of those decisions there and then. Which is important to sort of think about. There isn't really a stage where you help people to get into the right mindset to be able to answer those questions or to consider what those questions really should be in the first place. So bear that in mind. But also people are not really feeling listened to within that section. So if you're a patient yourself or you're caring for somebody, you sort of know what's going to be best for that person. You've got an idea as to what care provision is going to work for you. And quite often people don't really feel that voice is taken forward. Occasionally you get ladies occasions like this. This photo is from a lady who's asked for the sort of medical history of her husband so frequently that she carries it around in her purse, just in case something happens to him and she needs to inform some healthcare professionals as to what's recently happened. But even when you find people who are sort of informing themselves to ready themselves for these conversations, they find that they're having those conversations over and over again with different professionals. They don't know where that information is going. They don't know what it's being used for. And it's also kind of exhausting for them to continuously be giving out the same information and not really seeing anything being processed from it. So there's not a lot of feedback coming back from that. And thirdly, people aren't really supported to make those decisions as to the type of care that they're going to need when leaving hospital. So on one hand, we met 2 ladies whose stories up in pink there, who'd sort of witnessed their mother in hospital using a certain type of cup that allowed her to keep herself hydrated during the time that she was in hospital. It meant that someone didn't have to keep coming over and helping her to drink. She was able to do it herself, keeping herself sort of independent and dignified. So they're like, that's great, we'll get one of them for mum. Let's just go on Amazon, find one. It's cheap, it's delivered. We know it's going to be at the house in time, and we know that it's not something which is going to need to involve an assessment and a social worker and lots of paperwork. Because the alternative for them was really cumbersome. There's not really a sort of lightweight option of I just want someone to help me find the right stuff, or I just want someone to maybe pop in once a day or twice a day. There's not really a sort of lightweight social care option. You're immediately into assessments and visits and really sort of cumbersome stuff. But on the other hand, the main photo is actually a picture of something called a care plan. It's really rare to see these out in the wild. These are often things which rarely get printed off. They sort of live in databases. They're very rarely looked at. But we found one of these in a living room in Essex. Essentially, it was there to make sure that the carers who were coming round twice a day didn't get this older gentleman mixed up with the 17 other people that they're seeing during the day, which is quite sad in itself. But it also shows the fact that these plans are really inflexible. So at the point when you leave hospital, you speak to a number of healthcare professionals who help put this plan in place for you. You might have some input into that, or it might be decided for you based on the sort of structure of packages that are already in place within the IT system. But it means that as you are getting that care, if your needs should change or something should adjust, you kind of have to go back through the loop of full assessments and things like that. There's not really an alternative to adjust and arrange this. They feel like really difficult things to have an input into, so people's voices are not really being heard within that. So those three main things just to bear in mind. So what we're talking about today is actually how can we take that forward? How can we take all those learnings and start thinking about redesigning that service so that people are right in the middle of it, so that they are actually given a bit more choice and control should they want to take it, to actually look at how this process of leaving hospital can be a little bit better for everyone. How can we speed it up for individuals? How can we make it better for healthcare professionals needing and wanting to help people? And how can we make it sort of better for the care marketplace in itself to learn from what people are needing? So, how might we do these sorts of things? How might we create opportunities for professionals and patients to feed into their own plans, to actually put their voice forward and the things that they know will be useful for their loved ones? How might we help people to understand and communicate what it is that they need? How might we sort of reconsider that stage where you're constantly being asked what it is that you're going to need and get people into that right mindset? And how might we equip people with the right tools to organise care and support or plan towards it? Now, these are very designery words, but what we're doing at the moment is sort of taking these statements out, starting to prototype them, starting to test them, and starting to get an idea as to some of these assumptions. Are these really going to work? So, as I mentioned at the start, this is a live project. We're in the middle of it now. The story doesn't yet have an ending, but I'm a big fan of sharing stuff right in the middle of it. So not afraid to show sketches, show things as they're happening. This doesn't have answers yet, so I'm hoping that we can have a bit more of a discussion as to where this is going and how it's working. So what we're prototyping at the moment is one thing, which starts to ask the questions as to how can we help people to sort of give them time and space and headspace to actually consider what it is they're going to need to ask of people, and introducing them to some of the language, making some of that language a little bit clearer, and just sort of helping people to have open conversations amongst their families and with their healthcare professionals to actually make sure that those moments where they do interact with healthcare professionals or social workers or people who are going to give them assessments are made most of. So helping people to prepare for that and looking at the various ways that we can do that. We're also looking at ways in which that we can help people to tell their story. So that lady who carries around the copy of her husband's medical history in her purse, what could an alternative to that sort of look like, which means that I'm in control of my own data, I carry it around with me, and I'm in control of who and when I can share that with, maybe with lots of different variables, so I can make sure that as and when I'm rushed into hospital, the person who needs to know that data gets it immediately and can use it to help inform those decisions. And we sort of firmly believe that by these prototypes aren't quite right yet, but they start the conversation around what would it mean for patients to be in control of their own data, and we think that that's a really useful thing to do in itself. And thirdly, we're sort of looking at ways that we can sort of start to challenge the way that the care provider network and sort of whole marketplace is looking, and actually how we can bring people around a patient at that moment where they are needing to leave care, and look at sort of ways in which that we can make that easier, because often we've spoke to many people in hospital who were staying there for an extra couple of days because the transport hadn't been arranged or it hadn't been agreed as to who was going to pay for the ambulance with the certain mobility requirements. And the longer that you stay in hospital when you don't need to, the more likely you are to get an infection and need to be readmitted. So it's little things that can help to speed up that process that really make it better for everybody. So starting to look at the ways in which that we can start to pull people around an individual and help to make those plans as sort of streamlined as possible. So we're testing it. we know that those prototypes are a little bit out there. They're going to create a little bit of good response from people, but the reason that we create prototypes early and put them out in the hands of users is because we want to test these riskiest assumptions. We know that what we're trying to do is different. It's a big change. It asks people to think about things slightly differently. So we're taking prototypes out, we're speaking to more people, and we're trying to get to the answers around these particular types of questions to make sure that we are on the right track, to make sure that there are going to be enough people who will opt into this type of service to be able to use it. So we're doing what we always do, what we in this room know to do best. We start quickly, you start with lo-fi stuff, you start with sketches, you start with descriptions around that, with tools that already exist on the internet that you can make use of, and you just start slowly, little by little, in order to introduce those ideas and build up the case for them. So, back to the original question. So what are we really learning about putting people in the centre of their services? Because we're not quite finished yet. So while we're in the middle of this, we're sort of learning that this approach does have limitations. It is a little bit frustrating if you're asking someone to do something different from the norm, if you're having to explain something slightly different and create a different context around it. We know that this change is going to be slow. It might not scale. We're starting in one hospital. We're hoping to bring it to the other 7 hospitals in Essex. And we're looking for other similar populations that we can start to test it out with. And we know that our users are going to have different experiences. They know it's going to be fully different if someone's going into hospital with a sort of predicted knee operation and they've got an idea as to what their life is going to look like afterwards. They're able to plan for that versus someone who's been rushed in having had a stroke. Actually, what are the differences in terms of experience over that time? So actually, how do we bear that in mind as and when we're testing and collating our results and thinking about iterating? How do we sort of bear all of that in mind? But why are we doing it? We firmly believe that actually sort of reconsidering the way that service is running, is put together, and by putting more choice and control into the hands of patients and their families is the way that we're going to redesign these services and make the experiences of adjusting to a new form of life, a new stage of life, not necessarily enjoyable, but easier for people. So removing some of the barriers, making it easy for them to be sort of part of their own, of controlling what it is, what the next stages are going to look for them is vastly important. And that's sort of really what we're working for, is to make sure that those services are considered with the people right at the centre of them and thinking about how they own and use their own data, largely. So, I hope that was quick. Sorry if it was too quick.